So when a patient experiences a non-emergency change in condition after hours, simply calling the doctor to discuss the situation is inadequate. The problem is the phone. It's not good enough. Why? Well, doctors can't easily access patients' chart information like recent vital signs or assessments, and there could be language barriers on both sides of the conversation, and doctors often feel underinformed, so they simply send the patient out to the ER where they can get an assessment or an evaluation that they can trust. Now, this can lead to poor patient experiences as people are shuttled back and forth between care settings, often unnecessarily. And our facilities lose revenue when we don't have a head in the bed at midnight. And increased rehospitalizations mean poor relationships with our acute care partners. Now, we know that we can manage these patients in place. So by moving beyond just a voice-only communication, we believe we could help keep patients in the right care setting. And implementing telehealth, robust telehealth, could give doctors the knowledge that they need to make a more informed decision better than with just voice only. So what did we do? We went into the market and we introduced a $12,000 video cart with a remote telehealth provider attached that our nurses were terrified to touch. It just was so complex. It had non-intuitive interfaces. It had zero integration with our medical chart, and the doctors, on the other hand, had no information about the patient's medical information besides what the nurses could relay or what could be observed. Our contract said we could only use this with our skilled patients, and it cost us $4,000 per month per facility, and we were only using it 2 to 3 times a month. So what did we do? Well, first what we did was we expanded our on-site APN coverage to every day from 8 a.m. to 6 p.m. and we contracted with that same APN group to provide our remote coverage after hours. And we traded in the big scary robot for a more streamlined replacement. And we introduced Curatest. It's a progressive web app that pulls our patient's data right from the chart and presents it during the telehealth encounter. By marrying the voice and video with that patient's information, we could move beyond those limitations that voice-only or video-only encounters presented. So let's walk through a session. So a patient presents with a change in condition, say uncontrolled vomiting or changes in respiration. The nurse launches Curatest from any web-enabled device, and the application uses adaptive call routing to connect them to a remote caregiver, and they can start the session right from there. Now they can begin with a high-definition video session and begin using Bluetooth-attached medical devices like stethoscope, pulse ox, or blood pressure devices. Without leaving the screen, the clinician has access to the patient's medical chart. They can review labs, diagnoses, assessments, progress notes. As the nurse begins to treat this patient, it becomes more clear, where should this patient be? In our SNF or in the ER? They also have access to the patient's entire care team and can initiate third-party calls with assigned physicians or caseworkers, or even with the family members. And this is where we found our best value. By integrating the chart into the encounter, we could move beyond those limitations. The chart provides context for the encounter. It gives nuance and critical data needed to make an informed recommendation about where a patient should be. Now, family preference is a huge driver for avoidable hospital readmissions. Families often insist that we just send the patients back to the ER, even if we don't think that's the best option. We let our families know on admission about our state-of-the-art telehealth capabilities and how we can loop them in, too, if we need to. And we've continued to make refinements to the cart itself. We use FDA-approved medical peripherals, and we've increased to about 11 telemedicine video calls per building per month, with about 60 additional audio calls through the application to other team members or family members. The audio from the application is diagnostic grade. Clinicians aren't going to lose those high and low stethoscope sounds that can get dropped due to bandwidth restrictions. And the app easily goes into the room by itself on a tablet if there are isolation precautions, making for less equipment to disinfect, or to make it easier to document wound care. And our prices are way, way down. It now costs us about $3,000 on our Gen 2 cart, which is about 1/4 of the cost of what we originally tried. And our cost for our software and the APN coverage is about $2,000 per month per 100 beds. And that's half of what we were spending before, and we can use it for our entire population and not just our skilled. And now 92% of our patients who have a telehealth encounter now stay in our facility versus 77% when we started this in 2015. And we've had a lot of practice. We've had over 3,500 Curatest patient encounters since 2015. Over half of that has been for our skilled patients. And we are estimating that we have retained nearly $3 million in revenue from patients who have avoided a hospital transfer that we did not believe would result in a hospital admission. And we're able to leverage resources across our network, like having wound nurses in one facility, service patients in another. And we can set up remote check-ins throughout the night rather than waiting for something bad to respond. And we can easily loop in family members for video-enabled care plan conferences. Our liaisons in the hospital can now work with our clinical team to assess patients remotely prior to admission, and we're exploring partnerships with EDs to allow doctors there to assess our patients before we send them. And of course, CMS has proposed some telehealth policy changes which will change reimbursement. It's also a win for our nursing team because they become more engaged partners in the assessing of patients. It provides greater opportunities for ongoing training, and because we document each encounter as it occurs, we get immediate feedback on effectiveness. Our users tell us what works for them and what doesn't, and we're able to adjust our policies and procedures to match. Now, as patients and providers and families get more comfortable with telehealth, then we're looking for more and more opportunities to where we can leverage this, especially across the continuum in our independent living, assisted living, and home health. We want our patients and residents to be in the best care setting for their needs. Thank you.